Hi again, everybody. Our topic today is going to be endometrial hyperplasia. This is my second attempt at making this video. Some of you may have seen the first video I tried to put up on endometrial hyperplasia, and my voice got very strangely distorted. I tried to reload it a few times, but it kept coming out the same way. So I'm going to try re-recording it and see what happens. Hopefully it comes out normal this time. So endometrial hyperplasia is our discussion here. This is extremely common. This is something that will typically occur in perimenopausal women, but it tends to predominate in older women. You don't see it so much in younger women. And the reason you don't see it so much in younger women is that the endometrium normally gets larger during the menstrual cycle. And so what would be endometrial hyperplasia in a postmenopausal woman, let's say 10 millimeters, would be a normal thickness of the endometrium for a woman who is going through her cycle. The endometrium in a premenopausal woman can vary between 4 millimeters in the around right after menses and up to 16 millimeters or more during the secretory stage of the menstrual cycle. So although it's possible to have endometrial hyperplasia at any age, it tends to be symptomatic in women who are perimenopausal, in their late 40s, early 50s, and beyond. A 55-year-old woman presents to the clinic complaining of vaginal spotting over the last 3 months. She has no history of gynecologic problems. Menarche was at age 11. She's a G1P1001. She denies pelvic pain. Her past medical history is significant for hypertension, which is controlled, and obesity, a BMI of 30.5. She has been overweight since she was in grade school. She does not smoke or drink alcohol. Her medications include lisinopril and escitalopram, which is also known as Lexapro and SSRI. She's never used combined oral contraceptives. No family history of cancer. Her last PAP was 6 months ago. Speculum examination and bimanual examination are both unremarkable, though a small amount of blood is present on the glove. So this is a woman that presents with postmenopausal bleeding. I should have probably put in here when her last cycle was, but we can we'll just assume for our purposes here that she hit menopause around 52 years, which is the average age of menopause. But we can't assume that. I probably should have put that on here. But remember, the definition of menopause is once the menstrual cycle has ceased to occur for 1 year, and then we consider them in menopause. That doesn't mean that you can stop for a year. You can't stop for a year and then start having a cycle here and there. It can happen, but that's the definition of menopause. And so if a woman is starting to bleed or has any bleeding whatsoever, and she has not had her period in over a year, or she says she hasn't had her period in over a year, we consider that to be postmenopausal bleeding. All right, so what else do we have here? Well, let's go ahead and see what we should do for her workup. So what's the first thing you want to do for a woman who is around the age of menopause, who presents with bleeding? The same thing you want to do with any woman. So for any woman, I would say, for me, up to age 60, just because it's cheap, we're going to get a qualitative HCG. So you never know. Weirder things have happened. It is possible that she could be pregnant. And pregnancy is one of the most common causes of bleeding, of vaginal bleeding. We don't know if this is vaginal or uterine bleeding, so we're just going to call it vaginal bleeding because it's coming out the vagina. So we get a qualitative HCG. These tests are super cheap. It's just a pregnancy test, like what you can get over the counter. So it's cheap. Get it done. Then you have the HCG. You know she's not pregnant. That's negative. We're going to get CBC. Why do we get a CBC? Because it's possible to bleed from low platelets. You can get low platelets from all sorts of different things. We get a CBC, that's normal. Thyroid function tests. You could get by just getting a TSH. That's important to get because thyroid disturbances, both hypothyroidism and hyperthyroidism, can both cause abnormal uterine bleeding. We get all that, it's all normal. Now, some other tests you may get, depending on the woman, you may get liver function tests. If she has a history of alcohol abuse She could have cirrhosis. That can cause hyperestrogenism, and that can cause endometrial hyperplasia. And you'd want to know because that can be a sign of liver failure. And then another thing you may want to get, especially if she has a history of bleeding, let's say she bruises easily, or she had menorrhagia when she was having her cycles, you may want to get a PT and PTT to look for bleeding conditions. We get all that, it's all normal. Transvaginal sonography is in our next step. Why? Because endometrial hyperplasia is one of the most common causes of postmenopausal bleeding. There are other causes. The most common cause of postmenopausal bleeding would be endometrial atrophy, which can cause this spotting. The endometrium atrophies, and you can get unusual bleeding patterns. That's the most common cause of postmenopausal bleeding, and it's generally benign. It can be a sign, sort of a pre-malignant stuff, which we'll talk about in the endometrial cancer section. But that is the most common cause of endometrial bleeding. Right down next to that, then, is going to be endometrial hyperplasia. And we always need to look for that because endometrial hyperplasia can herald endometrial cancer. So we assess that by getting sonography. We get the sonography and it reveals an endometrial stripe measuring 6.2 millimeters. What's the cutoff? You may know this. The cutoff is 5 millimeters. So anything less than 5 millimeters is not going to be considered endometrial hyperplasia, and anything more than 5 millimeters will be considered endometrial hyperplasia. But this measurement is only for a postmenopausal woman. So if she is premenopausal, her endometrium can go beyond 5 millimeters and does go beyond 5 millimeters normally. When she is in her fertile period, she's easily 12, 13, 14, 15 millimeters. So you can't take that and apply it to premenopausal women. This only applies to postmenopausal women, which will be the majority of patients who present with endometrial hyperplasia. So 5 millimeters is the cutoff. We also see, though, that there are no polyps. Polyps is a little less common in postmenopausal women, but it is a possible cause. I think around 5 to 10% of bleeding in postmenopausal women will be caused by polyps. There are none there. And then the adnexa appears normal. So another possible cause of postmenopausal bleeding would be an ovarian tumor, which can secrete estrogen, and that can be there in consort with endometrial hyperplasia. You have estrogen secreted by the ovarian tumor. Here we'd be talking about a fecal lutein tumor, and that would then cause endometrial hyperplasia. And that can be a cancerous tumor of the ovary. That's normal. Okay, so that's not there. So what do we have here? We have a patient with risk factors for endometrial hyperplasia. We'll talk about these risk factors, but the major risk factor is hyperestrogenism. Now, the most common cause of hyperestrogenism, at least the most predictive form of hyperestrogenism that can cause endometrial hyperplasia, is the use of estrogen-containing supplements. And women who are postmenopausal will take these supplements a lot of times to abate some of the symptoms of menopause. That can be things like vaginal dryness. That can be things like mood swings, hot flashes. Taking estrogen will help with that. Some women will do that, but those things can cause endometrial hyperplasia. They can also cause endometrial cancer. They can also cause, they can increase your risk of breast cancer. So there are some drawbacks to that, so you want to know if she's taking that. Also, being overweight is a risk for being hyperestrogenic because, remember, adipose tissue creates estrogen. It converts estrogen. So that is important here, and we know that she is overweight. Her BMI is 30.5. Along with that, hypertension and diabetes, which she doesn't have, but hypertension is also a risk factor, probably because it comes along with obesity. And then never having used combined oral contraceptives, what we're going to see is the risk for endometrial hyperplasia comes along with your lifetime exposure to estrogen. So the longer you're exposed to estrogen, the more likely you are to develop endometrial hyperplasia. And being pregnant, using combined oral contraceptives, sort of relieve your body of that estrogen exposure temporarily or forever, for how long you're using combined oral contraceptives. So having ever used combined oral contraceptives, it does provide you with some sort of benefit, reduces your risk of endometrial hyperplasia. Same with being pregnant. So nulliparity is a risk factor, and never having used combined oral contraceptives is a risk factor. Okay, so we will talk briefly about the pathophysiology, we'll talk about the epidemiology and risk factors, and we'll go on to talk about how this shows up, how you work this up. The risk of cancer, I'm going to show you a bunch of pictures. You don't need to know about the pathology so much, how these show up on slides, but it's a good it's good to have it in your head, because what you will be expected to know is the description of the pathology and how that confers risk of cancer. And then we'll talk about treatment. Endometrial hyperplasia is an endometrial thickening with a proliferation of irregularly sized and shaped glands. And endometrial hyperplasia can vary, it's heterogeneous. The tissue can look just like normal endometrium, just you have more of it, or it can be very, very ominous looking with unusual cell shapes, unusual nuclei, an unusual geography. And as you can imagine, that's the one that correlates more with cancer, and this is why we get a biopsy. The class of hyperplasia is determined histologically, and endometrial biopsy is the test of choice when endometrial hyperplasia is suspected based on clinical presentation and imaging. So when we get that ultrasound on a postmenopausal woman and it measures, the endometrial stripe measures more than 5 millimeters, we get a biopsy all the time, no matter what. Now, if we're talking about a premenopausal woman, it can be a little difficult because the bleeding can be from all sorts of different causes, and we don't know if the endometrial stripe is abnormal or not, because it really depends on where she's at in her cycle. So it's a little bit more complicated for that. We'll talk about that. Endometrial hyperplasia is a response to estrogen. Endometrial tissue is extremely responsive to estrogen. It's got lots of estrogen receptors, and so women who have factors that cause them to be hyperestrogenic will be at risk for endometrial hyperplasia. So obesity, use of exogenous estrogens, liver failure, and so forth. Women of all ages can be affected, but it's more common in postmenopausal women. Why? Not exactly sure, but a possibility is that women who are premenopausal, if they bleed, they'll attribute it to their period and they won't go in to be seen. Women who are postmenopausal, say you're 55, 60 years old, you haven't bled in a long time, now you see blood in your underwear, you realize it's coming from your vagina, and that's going to be disturbing because that's not normal. And so these women will go in. Now, I don't know if that's the only reason behind why it's more common in postmenopausal women, but that certainly can contribute artificially to these statistics. Endometrial hyperplasia may be a precancerous lesion, although the majority of cases of endometrial hyperplasia will not go on to form endometrial cancer. And here, namely, we're talking about the endometrial adenocarcinoma, the most common form of endometrial cancer. All endometrial adenocarcinomas, however, do develop from endometrial hyperplasia. So that's why we're concerned about it, because it can be a precancerous lesion. Not always, but it can be. 1 in 38 women in the U.S. will develop endometrial cancer in their lifetime. That's a lot. That's about 2 to 3%. So if you take 40 or 50 women, one of them will develop endometrial cancer in her lifetime. That being said, although endometrial cancer is a very common form of cancer, it's the 4th most common cause of cancer in women, the number 1 cause of reproductive tract cancer in women. It is not a very common cause of cancer death. It's only number 8. So that's not very high considering how common it is. Risk factors. Hyperestrogenism is the number 1 risk factor, and out of that, the one that is most likely to cause hyperplasia from hyperestrogenism is the use of those postmenopausal estrogen supplements that some women will take. Obesity, we already talked about that. Nulliparity, early menarche, and late menopause. So we saw in this woman, her menarche started at age 11. What's the average age for menarche in the U.S.? 12 years and, I would say approximately 5 months. So 12.4 years. That's the average age of menarche in the U.S., and that age is dropping. So 100 years ago, it was like around 14 or 15. That age is probably dropping because of the childhood obesity rate. They're making more estrogen, and it's going to cause them to have their menarche earlier. Late menopause as well, it's all going along with that lifetime estrogen exposure. The use of tamoxifen. What is tamoxifen? It's a selective estrogen receptor modulator. That means that it acts like an estrogen in some places in the body, but it acts as an estrogen antagonist in other areas of the body. Namely, tamoxifen acts as an estrogen agonist in the endometrium, but an estrogen antagonist in the breast. And this is a drug that is given for estrogen-sensitive breast cancer. So when you have breast cancer, we take a biopsy, we stain it to see if it's estrogen, progesterone positive, receptor positive, and if it is, we use tamoxifen because that helps with the cure of breast cancer. However, that tamoxifen, although it acts as an antagonist in the breast tissue, it acts as an agonist in the endometrial tissue. And so you can imagine then that that is going to increase your risk of endometrial hyperplasia. Polycystic ovarian syndrome, that is a syndrome of anovulation. Remember that when you ovulate, that then is going to secrete progesterone and the estrogen drops. So if you're not ovulating, you're in a hyperestrogenic state. You have unopposed estrogen. That's going to increase risk as well. And remember that polycystic ovarian syndrome is also associated with some other risk factors that increase your risk of endometrial hyperplasia, such as type 2 diabetes and hypertension. So type 2 diabetes and hypertension, what do these have in common? Well, they're both going to be seen more in obese patients. So I'm not sure if these are independent risk factors or not, but they are listed. Same with gallbladder disease, also more common in obese women. Remember, gallbladder disease, fat, female, fertile, and 40. Okay, white race, not sure why, but we do know that endometrial hyperplasia, endometrial adenocarcinoma is more common in white women than in black women, whereas the other forms of endometrial cancer, the serous carcinoma and the clear cell carcinoma, are more prevalent in black women than in white women. So you will see this more, it will predominate more in white women. Higher socioeconomic status, not sure. Older age, and then living in North America or Northern Europe. So Northern Europe would be countries like Sweden, Norway, Denmark, Finland, Iceland probably too. So not sure why that is either, but there may be some confounding factors with white. Obviously, lots of white people in Northern Europe. They tend to be pretty well off, pretty well educated in Northern Europe, so that may confound things too. I didn't see any studies to suggest that endometrial hyperplasia is more common in Swedish Americans, for instance. So people who aren't living in Northern Europe but happen to have that ancestry. So not sure about that. But these are your risk factors. The ones I want you to take away from this, though, are hyperestrogenism, namely these menopausal estrogens and obesity. How does this present? Abnormal uterine bleeding is the most common presentation of endometrial hyperplasia. For postmenopausal women, that's pretty straightforward. Any bleeding is abnormal in a postmenopausal woman. So that's an instant indication to work her up. And for the most part, we're going to be going and getting a transvaginal ultrasound. For a premenopausal woman, how would this present? It can be difficult, and a lot of them won't come in because they just assume it's normal. So it may show up as menorrhagia because the endometrium is getting thickened. It may show up as intramenstrual spotting because you have a endometrium that is responding to estrogen that's not associated with the cycle, and so it stays thickened. So you'll have spotting in between periods. So really anything abnormal that's not syncing with the cycles, menorrhagia in a premenopausal woman, you're going to consider abnormal, and you'll consider endometrial hyperplasia. For postmenopausal women, which will be the majority of cases where we're considering endometrial hyperplasia, it's any bleeding. A detailed history is useful in determining the patient's risk for endometrial hyperplasia and carcinoma. So you want to know if she's taken or is taking any postmenopausal estrogen supplements. Is she taking tamoxifen, or has she taken tamoxifen? That's going to be done when you get a cancer history. So you want to know about her cancer history, her personal cancer history, if she's ever had cancer. You also want to know about first-degree relatives. So if you ask somebody, is there any cancer in your family? They're going to tell you all sorts of things. Cancer's common. So, oh yeah, my cousin had this cancer, my cousin-in-law had that cancer, my dog had this cancer, my grandpa had this cancer, my dad was a smoker for 40 years and he developed lung cancer. That's not very helpful. What we want to know is siblings, first degree relatives, and then if there's a preponderance of cancer, then go on to get cousins, grandparents. One of the things that we're going to talk about in the endometrial carcinoma section is something called Lynch syndrome. This is going to predispose you to endometrial cancer. This is a cancer syndrome. It's caused by a mutation. It's also associated with colon cancer. And endometrial cancer is the number 2 cancer that occurs in Lynch syndrome. So you'll hear the colon cancer that comes out of Lynch syndrome called HNPCC, hereditary non-polyposis colorectal cancer. So we'll talk about that a little bit more in the endometrial carcinoma section. You want to know about her obstetric history. If she's nulliparous, that's going to increase her risk. Onset of menarche and menopause, and if she's ever had any gynecologic problems. Mainly here we're looking for PCOS. So to work her up, because the most common presentation of endometrial hyperplasia is abnormal uterine bleeding, we're going to be working her up for that symptom, looking for sources of bleeding. So we do a pelvic exam. So we do our gross examination with a speculum. We want to look for things like lacerations. Women who are postmenopausal, their vaginal tissue, vulvar tissue begins to sort of atrophy, gets dry. When they're having intercourse, they're prone to get lacerations. So that's something you want to look for. You also want to look for things like foreign bodies in any woman. And then another thing you want to look for is cervical cancer. Now that can be difficult to see grossly unless it's progressed, but cervical cancer can be a cause of bleeding. Less than 1% of postmenopausal bleeding cases are cervical cancer, but keep an eye out for that. And that's one of the reasons why we want to make sure that her pap is up to date. And then by manual examination, certainly feeling for any masses that may be present. Fibroids can cause bleeding. Ovarian tumors, as we mentioned, can cause bleeding. Polyps can cause bleeding. So feel for those. Then we get our labs. We get a qualitative HCG to make sure she's not pregnant. We get a CBC to look for platelets. We also can take a glance at her red blood cell count and hemoglobin to look for any possible anemia that may have came out of this. We look at her thyroid function, and then we want to ensure, as I mentioned, that her pap is up to date. For imaging, we get a transvaginal sonography, and we measure the endometrial stripe. But we'll also look for any possible masses inside the uterus or out. Transvaginal sonography is the imaging test of choice for women with suspected endometrial hyperplasia after clinical and laboratory workup, and it's the thickness of the endometrium that's the primary determinant in whether or not you'll go forward with an endometrial biopsy. I didn't include any pictures here, unfortunately. I didn't include any pictures of the transvaginal sonography, but it's quite easy to determine the endometrial thickness. You just look; there will be a border. If you look at where the lumen, the inside of the uterus is, and then you'll see that the uterus is lined with echogenic tissue. If you go from there and you go inward towards the serosa of the uterus, you'll see there will be a border of whitish tissue and then darker tissue on the ultrasound, and you're going to measure from side to side. And if you go onto the endometrial cancer section, I do demonstrate this, so I'm not going to go into this in too great of detail. For postmenopausal women, if the endometrial stripe is less than 5 millimeters, it's probably endometrial atrophy. If the endometrial stripe is greater than 5 millimeters, it's likely caused by endometrial hyperplasia. Endometrial atrophy is the #1 cause of postmenopausal bleeding, and that can be quite normal. Endometrial hyperplasia is what we got to test, and we do that with biopsy. So if the endometrial stripe is more than 5 millimeters, we go on to get a biopsy. For premenopausal women, there are no consensus guidelines that exist. The normal endometrium can vary from 4 millimeters to more than 16 millimeters. So an ultrasound is good for looking for any masses. Fibroids can be a common cause of bleeding in premenopausal women, polyps. So the sonography is useful, but the endometrial stripe measurement is not so much useful. So for premenopausal women, we're going to look at her risk factors for endometrial cancer, and we'll make a measured clinical judgment based on that. So if her age is more than 40, certainly her risk goes up. Risk for endometrial cancer goes up with age. If she has any risk factors for endometrial carcinoma, so certainly if there's a family history of endometrial cancer, if she's overweight, if she, let's say, had her ovaries taken out and she's taking estrogen supplements, if she's null paris, you just got to take all these risk factors into account. And if she's got these risk factors, you just make a clinical judgment and determine whether or not you want to get a biopsy. If there's significant intermenstrual bleeding, that's always abnormal. So in that case, you'll want to get a biopsy. Or if she has gotten treatment for endometrial hyperplasia with progestins and she's failed to respond to that, we're going to talk about this when we talk about treatment, you'll get a biopsy there too. These indications are from ACOG, but certainly it's not a consensus. So there are no consensus guidelines that exist. You just have to use your clinical judgment. On USMLE, step 2, step 3, if you get a test question on endometrial hyperplasia, they're going to give you a postmenopausal woman, just to make this clear. So how do we get these biopsies? They have these prepackaged sort of pipettes, and what they are is a hollow tube, and then inside you get this little piston. And you stick this tube up the cervix into the uterus until you reach resistance. And then once you reach resistance, you pull the piston out. It creates suction, and you'll kind of feel that sort of pop a little bit. And then you're going to take that the pipette and you'll twist it around. You'll make sure you twist it 360 degrees, kind of pull it in and out, gently hitting the uterus, and then once you pull it out, then you'll see that you have a little wad of tissue, and there you'll take that and send it for pathology. Now, unfortunately, endometrial cancer can be in little foci, and you might not hit that area. So that is one of the limitations of this. Important histologic terms. So now we're going to talk about what happens when we get the biopsy. I'm going to show you some pictures. That's more to just cement this into your head. But what you want to focus on for test-taking purposes is the histologic terms. So on the test, you're not going to get any pictures. If you're watching this and you're going to be taking USMLE Step 1, then you do want to know what an endometrial biopsy looks like, because that will be on the test. That's certainly fair game. Step 2 and Step 3, though, you want to know if a biopsy comes back and they give you a vignette, patient with endometrial hyperplasia, get a biopsy, and it comes back as, let's say, complex with atypia. You want to know what that means versus if it's simple without atypia, because that's going to dictate your treatment. Okay, so simple. What does it mean if it's simple? Well, simple means it looks normal. So it's normal endometrial architecture, maybe some increased glands and stroma. What this means is that you have endometrial hyperplasia, but the tissue looks normal. You just have more of it. The gland to stroma ratio is normally around 1:1. So the area of gland, including the lumen, should be roughly equal to the area of stroma, the tissue that surrounds the gland. It may be a little bit increased in simple hyperplasia, but not by much. So it may be slightly increased from 1:1, maybe 1.5 to 1. Complex hyperplasia is where you get visible changes in the architecture, and mainly here we're talking about crowding of these glands. So the glands will be kind of pushed together. You don't have as much intervening stroma. You can get some invaginations of the gland. They sort of change shape. Or you can get, you can get an increased gland to stroma ratio. If you have crowding, you're going to have an increased gland to stroma ratio. Usually it's going to be more than 3:1. And then atypia just refers to changes in the nuclear structure of the cell. So things like round nuclei, variations in the shape, size, or staining pattern of the nuclei, hyperchromia. You can have coarsely clumped chromatin. The nucleoli can be more prominent. You also see that the nuclei normally are in this sort of line parallel to the lumen. That will be disturbed too. So I'll show you some pictures of that so you get an idea of what atypia is. But atypia is the one thing in the pathology report you want to be most concerned about, because anything with atypia is concerning for cancer. Whether or not there's an invasion of the stroma or myometrium will be useful in determining whether or not there's endometrial cancer. We're not going to see myometrium in our normal endometrial biopsy, endometrial sampling. We don't get myometrial tissue, so we want to look for invasion of the stroma. The pathologist will do all this for you, so you don't need to be concerned about any of this. But you want to know what simple, complex, and atypia mean, and mostly you want to know what risk that confers for developing cancer, and what risk or what that risk means for how we do our treatment. Okay, so this is normal endometrial tissue. As you can see, if you take the area of the lumen and the area of the stroma, it's about the same. What I want you, this is stroma, by the way, here, this lighter colored tissue, and this is more darker purplish colored tissue is, these are glands, and then obviously this is lumen. So you can see here, there's no atypia. These nuclei are sort of in a line more or less parallel to the border of the lumen. And this is going to become disturbed when you have atypia. This is simple endometrial hyperplasia. So it looks a lot like normal endometrial tissue. It's maybe a little bit more than 1-to-1, but otherwise it looks pretty normal. Now there is one thing that can help you determine simple endometrial hyperplasia besides the fact that on ultrasound you're more than 5 millimeters in a postmenopausal woman, and that is the number of cells that make up these glands. So you can see here that there aren't quite as many cells in normal endometrial glands as there are in these more abnormal appearing ones. So look at how many cells there are here. If we were to count the nuclei, you would see there are much more cells than in this normal endometrial tissue. So dilated, larger endometrial glands is associated with endometrial hyperplasia. But these glands otherwise look normal, and there's no atypia. So that's simple endometrial hyperplasia with no atypia. You can have atypia in simple endometrial hyperplasia, and you always want to look at the nuclei, but simple endometrial hyperplasia with atypia is quite uncommon. Okay, now this is complex endometrial hyperplasia, and this is what those glands look like when they sort of invaginate. These glands become somewhat irregular. Look at these glands. They're more or less ovoid in shape. These glands sort of invaginate. They form these sort of, I don't know what you'd call it, branches. So this is abnormal. And the gland to stroma ratio is a little bit more, quite a bit more than 1-to-1. And you'll see that better in the next picture here. So if you take, so you have to look closely here. This is the border of the gland here, and then the lumen. So you get a little bit of crowding, these glands that get pushed up next to each other. But look at these nuclei. They look pretty normal. You'd have to look a little bit closer, but kind of look at the staining pattern and see that they're more or less in a pretty straight line. So this looks to me like there's no atypia. Same here. But look at here, there's crowding. There's not very much intervening stroma here. You just have a lot of glands, and then you have some with these abnormal patterns. This is complex hyperplasia, when you have crowding or this sort of branching abnormal pattern of the glands. Complex. Okay, again here, crowding and this sort of branching pattern. Okay, so this is what no atypia looks like. Look at how nice and lined up these are. The nuclei are roughly ovoid in shape. They all stain about the same, and they're more or less parallel with the lumen. Same here. I think this is that original picture I showed you of normal endometrial tissue. Okay, this is atypia. You can see that these nuclei are in all sorts of different places. You see some mitotic figures here, maybe here too. But these nuclei are staining a little bit lighter. and some are staying a little bit darker. So there's some variation, and they're not parallel to the lumen. So this is atypia. And what the pathologist will really be looking for is those mitotic figures. A couple mitotic figures here and there is not unusual, but if there's a lot of them, that's considered atypia. And this is always concerning. You're never going to have endometrial cancer without atypia. Atypia is associated with malignancy, but you can have atypia and not have cancer. Okay, this is atypia 2, a little bit more discrete, but you can see there's nuclei down here. Not seeing any mitotic figures here, but you can see the pattern of the nuclei is a little bit different. Okay, so you decide whether or not the pathologist will decide whether or not it's simple or complex, whether or not there's atypia, and then there's 4 different possibilities. So simple without atypia, complex without atypia, simple with atypia, and complex with atypia. Like I told you, simple with atypia is quite rare. So if it's simple without atypia, the risk of progression to cancer is 1%. So not common to progress on to cancer if you have simple without atypia. This is the best prognosis. If it's complex without atypia, the risk is 3%. If it's simple with atypia, it's 8%. But if it's complex with atypia, this is one we're most concerned about, the risk is 29%. So you can see that the most ominous feature that we can get from the biopsy is atypia. Simple versus complex, yes, complex is worse, but it's the atypia that we're most concerned about. So if there is atypia, that is going to dictate a different treatment plan than if there is not atypia. Not so much simple versus complex, but whether or not there is atypia. That's what you got to keep an eye out for. So the therapy is going to depend on a few things. It's going to depend on the woman's age. It's going to depend on whether or not there's atypia, as we mentioned, and then it's also going to depend on whether or not she wants to remain fertile, because in some cases, if there's atypia, we prefer to treat it with hysterectomy. So if she's postmenopausal or if she does not care to get pregnant in the future, then we can do a hysterectomy in those cases. Now, most cases will present without atypia. So if there's no atypia, then we determine whether or not she's menopausal. If she's postmenopausal, we do something different than if she's premenopausal. But the treatment is the same as far as the drug we use. So if there's no atypia, we treat this medically. And we use the medroxyprogesterone acetate, also known as MDPA. And this is a progestin. So this is also known as Provera. You'll hear it referred to. That's the name brand. So if she's premenopausal or postmenopausal, we're going to give her Provera. The difference here, though, is the dosage. So if she's premenopausal, we give her more. We give it 10 to 20 milligrams every day for 2 weeks, and then we withdraw it for 2 weeks. And we do this for 3 to 6 months. If she's postmenopausal, we go 3 to 6 months, but we give her 2.5 milligrams every day continuously. We don't pause. So this is the treatment regimen for patients with endometrial hyperplasia without atypia. For the test, you should just know we give Provera, MDPA. So we do that for 3 to 6 months, and then we get a repeat biopsy. But we have to make sure that we stop the Provera for 2 to 6 weeks before we get the biopsy. Why? Because Provera will change the endometrial architecture, and we don't really get anything useful out of that biopsy. So we want to stop the progestins for 2 to 6 weeks, let the tissue go back to what it would normally be, and then we get the biopsy. So 2 to 6 weeks. When we get the biopsy, we look for regression. If there is regression to normal endometrial tissue, good, we're done. If there is no regression, then we're going to give her a higher dose of MDPA, or we can give her Megestrol. And then we'll just repeat and then check for regression again. If there's no response, continuously no response, then you can consider the possibility of just removing the uterus if that's something the woman can agree with. But what I want you to know for the test is that if there's no atypia, we do medical management, we give her Provera, we follow that up with a biopsy, no change, we give a higher dose Provera, or we give Megestrol, and then repeat. Now, if there is atypia, the preferred treatment is going to be hysterectomy because the risk of cancer is so high. It can be up to 30%. So if there is atypia, preferred treatment is hysterectomy. And the majority of patients are postmenopausal, so they'll be totally fine with that. Most of them don't care to have their uterus anymore after it's not there. Really, the uterus, after menopause, the uterus and the ovaries, the only purpose they serve is to be a hotbed for cancer. So having that removed is totally fine. There's no side effects for these women. So a lot of women will be conducive to that. On the other hand, if you're dealing with a premenopausal woman, she may very well, and for good reason, want to keep her uterus because she wants to keep her fertility. Fertility is really not the best word to use here because she's still going to be fertile if she keeps her ovaries. She just won't be able to bear children. She can still have her own biologic children, but we're just going to use the word fertility here. So if she wants to preserve her fertility, preserve her ability to bear children, we can do that, but we have to be very careful. So what we're going to do is we're going to tell her, okay, please have children as soon as you can. Have your children, and then once you're done, then we want to do a hysterectomy to abolish your risk of endometrial cancer. In the meantime, when she's not trying to have children, and before we do a hysterectomy, we're going to be giving her high-dose Provera. And then we want to follow up every 3 months with a biopsy. And if it comes back for cancer, as we're going to talk about, then we really need to consider doing a hysterectomy. But once she's done bearing children, we will get a hysterectomy.